The following podcast is part of a certified educational activity titled Control Myelofibrosis: Current Options, New Treatment Principles, and Opportunities to Leverage JAK Inhibitor Platforms and Novel Mechanisms of Action. Access the entire activity and complete the post-test at peerview.com/AQJ860. Downloadable slides and practice aids are also available.
Everyone, welcome. So myelofibrosis is an interesting and challenging disease. Clearly, its name is really quite historical in nature, but really was agnostic to the time where we knew what was going on with the disease. Clearly, the name means nothing more than scarring in the bone marrow. However, we've learned over time that this is clearly a disease that is clonal in nature with a secondary reactive fibrosis that leads to a range of distinctive phenotypic features: cytopenias, leukoerythroblastosis, splenomegaly, symptoms, as well as risk of thrombosis and hemorrhage. And in many ways can be both a progressive phase of either essential thrombocythemia or polycythemia vera, as well as present on its own. It also has the potential of progressing to acute leukemia, although certainly can be life-threatening even without that transformation. The workup for myelofibrosis, and these are the current NCCN recommendations, really include, at its core, a bone marrow biopsy with cytogenetics, reticulin stain, and I think nowadays molecular testing, including the core driver mutations of JAK2, CALR, and MPL, as well as likely an NGS panel. But in addition to this, accurately assessing the spleen, measuring symptoms from the patient using the validated MPN-10, as well as potentially HLA typing, serum EPO, coagulation tests, etc. Now, it's a disease with quite a heterogeneous natural history. And because of that, there has been many efforts to try to quantify risk, as well as stratifying risk for the selection of therapy. For the NCCN guidelines, they had an opportunity to be the inaugural panel chair. We decided to really stratify people into lower risk or higher risk, and that plays a role in our selection of therapy. The prognostic scores themselves, there are many of them. It's not worthwhile really memorizing how to calculate them, but to know where they are, where you can find them, and that the features that can be predictive of both premature survival or progression to acute leukemia include cytopenias, fibrosis, symptoms, molecular mutations. The molecular mutations, as well as anemia, perhaps some of the strongest negative prognostic implications. And in the ideal world, you have all of these variables to be able to assess risk. Now, as we think about JAK inhibition, or thinking about them really as a platform for therapy, indeed, even today as we talk about combination approaches, I'm mindful around ASCO, there are not many diseases left that we treat as monotherapy. In myeloma, they have 4 drugs. They may well be using 8 drugs by the time ASCO is over. But, we're really only starting that journey. But fortunately, we have a very strong base with JAK inhibition. They've made a real impact for patients. We have ruxolitinib, the first approved. These are the formal indications. Ruxolitinib, fairly broad label, intermediate and high risk. Fedratinib, intermediate and high risk. Pacritinib, approved, particularly for individuals intermediate and high risk with a platelet count of less than 50,000. And momelotinib for those with anemia. So you see that there's overlap between those indications, but particular calling out of cytopenias for pacritinib and momelotinib. In addition, we'll go into a little bit greater depth of new mechanisms of action, telomerase inhibition, working on the apoptotic pathway with navitoclax, BET inhibition with pelabresib, a middlestat is that telomerase inhibitor, naftamatulin as an MDM2 inhibitor, selinexor as an XPO1 inhibitor, that all have very intriguing and positive data, but all potentially might have benefit either alone or in combination with JAK inhibition. Now, all of this discussion of medical therapy really extends after we factor in the role of stem cell transplantation. Suffice it to say, the timing of stem cell transplant is not a simple question. Certainly, there is a sweet spot. We've learned that we can wait too late and patients have had a chance to progress or develop additional comorbidities. But by the same token, we can do it too early and the risk of transplant can be difficult. This showing data from an analysis that I was involved with my mentee, Christina Gowan, through the CIB-MTR. And as we think about trying to optimize care with JAK inhibitors in myelofibrosis, clearly there can be a benefit. We realize that individuals that have significant cytopenias have overall done worse than those that have not, which is now a reason we're glad to have the additional JAK inhibitors, as well as it's been shown that if you fail a JAK inhibitor, survival can be shortened, particularly if you've had progression. Additionally, there are gaps out there. In real-world evidence, there has been a delay in starting patients on therapy that may have a negative consequence for patients, and certainly a delay in the utilization of second-line therapy. So our goals today are to really try to improve your understanding of these baseline characteristics that are prognostic for patients, to try to better understand both JAK inhibitors, but really what comes next in terms of these new therapies with novel mechanisms of action. What are we learning for them? Although this is not a large group of patients, roughly around 20,000 in the US, they are heterogeneous and increasingly trying to select therapies that really are more personalized for the patient is strongly desired. So let's go ahead and begin with around a case, and Dr. Prem-Raju will walk us through this first case.
Well, thank you, Ruben. To you and John, thanks for sharing this Jeopardy-style, debate-style podium with me. So Final Jeopardy is coming up soon. Team, I want to go through this in a more interactive way to be able to show that we've now entered into a golden era of treatment for myelofibrosis with JAK inhibitors remaining the backbone of that therapy with now 4 US FDA-approved choices. So two contrasting cases, we'll use the same patient in sort of 2 scenarios. Scenario 1, team, is that Jeffrey is a 67-year-old man who comes to your clinic with primary myelofibrosis. He has constitutional or B symptoms, palpable splenomegaly. He has thrombocytopenia, but with platelets above 50, so we'll say 100, 102 here with no anemia. And he has mutational testing that shows beyond the JAK2 mutation, also a TET2 and ASXL1 positivity. The patient is stem cell transplant eligible, but reflecting our real-world, real-life clinical practices, stem cell transplant is not happening right this moment. There's a delay, and so the question is, what are we going to use for upfront treatment? And then we'll also look at the second scenario, which is the same patient, Jeffrey, 67-year-old man with primary myelofibrosis, splenomegaly, constitutional symptoms, platelets of 102, no anemia, same mutations, but now the patient's already been initiated on frontline ruxolitinib, and then at some point develops progression, symptoms, and so now it's time to choose a second-line therapy. And so let's review together what are the evidence and data for second-line and beyond. So to do that for standard of care, in many of our clinics, we're still referring to the NCCN guidelines, still a very reliable source of information, even for our patients with hematologic malignancies. As you can see here, the treatment for higher risk MF, which for these purposes we'll define as intermediate to high risk by any scoring system that you use. I think the first rubric is to determine if your patient in front of you is stem cell transplant eligible or not. The reason for that, team, is that in 2024, allogeneic stem cell transplant remains the only curative modality for patients with myelofibrosis. But as Ruben just showed us, many of our patients are unable to get to transplant despite being eligible by the textbook definition. After you've determined that, let's look at platelets. Thrombocytopenia, using 50 as the cutoff. If you're below 50, we now have the FDA-approved drug of pacritinib, led by Dr. John Mascarenhas, to FDA approval specifically for patients below 50. That's based on the PERSIST-2 trial. We have momelotinib as well, which in the Momentum study, led by Ruben and Serge, that also actually allowed, did you know, platelets of 25 and higher. Platelets of 50 and higher, we have the 4 choices, as you see here. Ruxolitinib, the first approved, based on the COMFORT studies, led by Serge Verstovsek, Claire Harrison, and Ruben Mesa, New England Journal of Medicine, now over a decade plus ago. Fedratinib as another choice, based on the Jakarta trials, and then again, the momelotinib and pacritinib agents. Interestingly, most of us have seen in the clinic and in the clinical trials that usually by 3 to 6 months, you will see the peak effect of many of these JAK inhibitors. If the patient is not a stem cell transplant candidate, then again, JAK inhibitors, clinical trial, et cetera. Now, looking at ruxolitinib, now that we've had it in the clinic for 10 years plus, this drug, which really set the revolution, backbone for our JAK inhibitor field, has not only helped patients improve spleen and symptoms, but there's accumulating data potentially showing improvement in overall survival. Many of these are real-world data sets or retrospective analyses. Take a look at this one from our colleague, Dr. Guglielmelli in Italy, which is over 1,000-patient real-world database, kind of a stunning data set. And as you can see here, 10-year overall survival when compared with hydroxyurea versus ruxolitinib in what they call propensity score matching, a statistical method to kind of look at these retrospective real-world data sets. You can see the curves yourself here, a complete separation favoring the JAK inhibitor ruxolitinib over hydroxyurea as standard of care, and actually the widening of the curves over time. So compared with Hydrea, the ruxolitinib was shown to have significant benefit in terms of overall survival, and the benefit was also seen when they did the propensity score analysis within smaller samples. What about ruxolitinib in the peri and post-transplant setting? In addition to having the US FDA approval for myelofibrosis and advanced polycythemia vera, ruxolitinib also has an FDA approval in the GVHD setting, just of note and of interest here. But even without that GVHD signal, ruxolitinib in the peri and post-transplant setting, as shown by our colleague, Dr. Gabriela Hobbs from Mass General, you have a 1-year GVHD-free or relapse-free survival rate of 74%. And as you can see here, overall survival, progression-free survival, and cumulative incidence of this non-transplant related mortality and disease relapse are shown here. Interestingly, there were no new signals revealed. So as we expected, cytopenias, anemia, thrombocytopenia, and neutropenia were the most commonly seen hematologic abnormalities. So when we go back to the NCCN, we're talking about looking at a patient transplant eligible or not, platelet level, monitoring the response, looking at these patients in the clinic, monitoring the CBC, symptoms, and spleen. At the end of the day, we still prefer clinical trial for all of our patients, if able to, if feasible, and if it's available, even in the frontline setting. As you're gonna see, John will review the data. There are frontline combination studies that are in the clinic, even in the phase 3 setting. What about in the second line option? What about sequential JAK inhibitor therapy? We have data in our field that shows that this is feasible. This is fedratinib, which is the second approved drug, approved in August 2019 in the setting of either frontline or relapsed myelofibrosis. And here I'm showing you that fedratinib is a very viable sequential option for our patients after ruxolitinib. Based on the Freedom 2 study and also Jakarta 2, patients with myelofibrosis who previously had ruxolitinib can also gain an SVR, spleen volume reduction benefit, from use of the fedratinib agent, and also can have symptom benefit as well. In the real-world setting, John here has shown that we have evidence of sequential therapy with fedratinib, even in different settings, which really apply to the clinic. Here I'm showing you that spleen size decrease is seen with the fedratinib therapy. It can be durable, and it does happen rapidly in the setting of discontinuation of the ruxolitinib. And what about transplant with fedratinib? Also shown by John here, patients who were able to go on to receive stem cell transplant, this with a median follow-up of approximately 9.5 months. These patients were able to feasibly have the fedratinib agent and go on to have successful stem cell transplants, again offering a second JAK inhibitor in the setting of bridging to the curative allogeneic stem cell transplant. Further evidence here, based on this data set I just mentioned to you, is that transplant following fedratinib appears to be effective and safe for patients to be considered. And I might also add that oftentimes the performance status of our patients may improve after the JAK inhibitor. So you may have someone who's PS of 2 or 3, get one of these JAK inhibitors, improve to a 0 or 1, thereby becoming an even better candidate for allogeneic transplant. This is a very powerful data set John, led by you and colleagues. So where does that leave us with the final recommendations? Ruxolitinib, the first in class, the backbone, remains one of the most potent drugs in the field. We still continue to base it based on the platelet count. This is on the package label, as you can see, based on 200 or higher platelets, 100 to 200, 50 to 100. There are no new signals than the ones that we know about, the cytopenias that are well known, managed by dose reduction, interruption, or even transfusion in anemia, which can happen transiently, usually in the beginning. We're assessing patients for spleen and symptoms. We're looking out for side effects and toxicities, and we're monitoring these patients closely with CBC and chemistry panels. For the fedratinib, the 400 milligrams orally daily dosing with or without food. And of course, the safety consideration, we need to note that with each of these JAK inhibitors beyond Rux, slightly different from each other. This one, a GI signal, which is very real in the clinic, so most of us are watching this closely, prescribing antiemetics, antidiarrheals, and then the thiamine signal that you probably know about, a US FDA black box warning, originally for Wernicke's encephalopathy, but now more of an encephalopathy syndrome. So checking for thiamine, replacing thiamine, watching for either neurologic or GI side effects. And so we go back to our case of Jeffrey, the 67-year-old man with myelofibrosis, constitutional symptoms, splenomegaly, platelets just above 100, JAK2, TET2, ASXL1, and not able to find a donor. And so the question is, what available frontline options would you consider for this patient? Would you consider a JAK inhibitor prior to transplant or just a JAK inhibitor? And how would you select between available JAK inhibitor regimens? So this is, I think, a big question. Ruben, I think if I can just turn to you to help us guide through here.
Wonderful. Well, John, what do you think? What would be available frontline options for this patient?
So I think if you have a JAK inhibitor naive patient that has a platelet count that's above 100,000, I think it's ruxolitinib and or fedratinib, which we often sort of underappreciate in this role, as approved drugs. I think if the patient also has significant anemia involved, then one could consider momelotinib. You know, I think when the platelets are on the lower side, that's when you're looking at drugs like pacritinib in the front line.
Wonderful. And Naveen, clearly this individual is high risk. They don't have a donor yet. JAK inhibitor prior to transplant. Are there any situations where you've sent folks to your colleague Uday Popat without having had them on a JAK inhibitor first?
Very rarely, I would say. I would say both in a real-world situation and in our data, almost everyone will get some therapy, JAK inhibitor usually ruxolitinib in those cases if there's preserved platelets. Also because if you can reduce the spleen and the symptoms, maybe patient's performance status improves too before going to the transplant.
Wonderful. And we're going to transition to the next thing, but let's say this individual had a platelet count of 70,000. Would that change your initial selection, John?
You know, I think it provides other considerations. So, and I think we have enough data to suggest that you could go low and slow with ruxolitinib and try to titrate up to, you know, at least a minimally effective dose of 10 twice a day, or one could pivot to the alternative JAK inhibitors that are approved. Fedratinib has data, 50,000 and greater. Pacritinib, of course, did the PERSIST-2 and PERSIST-1 in any platelets, and platelets less than 100,000, which there's data, but approved under 50,000. And momelotinib has data in the Momentum study with 25,000 and greater. So I think it gives us a lot more leeway to pick drugs. And I think it's like most things, you know, there are options, and there may not always be the specific option in each, and you could sort of play around with it and sequence these drugs. And I'll point out something that I think, you know, is worth mentioning that some of the audience might be wondering is, does the molecular profile play a role? Does it help us guide selection? And I would argue it doesn't. So despite the fact that we all get NGS and we you know, dutifully quantitate how much JAK2 there is and what other alternative mutations are present, I would argue that it still doesn't really inform us on which JAK inhibitor is better to use. So really, it's pretty simplistic go. It's what is the platelet count? You know, maybe if the patient has some, you know, really bad IBS, I might want to avoid those that have FLT3 inhibitor activity. Maybe someone who has a drinking problem and potentially low vitamin B1, I might want to avoid one that might lead to Wernicke's encephalopathy. So sometimes the toxicity profile might help us as well.
Wonderful. Well, let's pivot on to the next case because it'll delve us. So here, let's take this same individual. So let's say they initiated on ruxolitinib, but subsequently experiences symptoms suggesting disease progression.
Right. Yeah, so perfect. So in this case, now we're in the second line setting. We reviewed, obviously, here the fedratinib agent, which has the data based on the Jakarta-2 Freedom studies. And then again, in the case of the platelets or anemia, then you've got the pacritinib and the momelotinib, which you'll be discussing here in a moment. And then again, looking to reassess if there's any clinical trials or stem cell transplant. And it's a good time for us to mention, we always think it's implicit, but as John was mentioning, it's not JAK2 mutant inhibitors for these standard of care, it's all comers. So CALR, MIPL, JAK, but the new era of JAK2 specific mutant inhibitors is starting. So for the purpose of this discussion, these apply to all of our mutations and all of our patients.
Wonderful. So what would you say are take-home points?
Quickly, Ruben, the take-home points I think are threefold. Stem cell transplant, allogeneic transplant remains the only curative modality as standard of care for patients with myelofibrosis. So that's the first cutoff. Two, you look at the platelets. If your platelets are preserved, you have the ruxolitinib and fedratinib. If not, then you have the momelotinib and pacritinib. And then three, keep thinking about clinical trials, even in the frontline setting, including the combinations.
Very good. There we go. Now, what if this person had a baseline anemia with a hemoglobin of 6.5? So let's get into this aspect, really focusing on anemia. So the 2024 NCCN guidelines for MF-associated anemia have recently been updated. And with these, individuals that have splenomegaly, they're symptomatic, they first have changed it to see if you're controlled on a JAK inhibitor or not controlled. If you're not controlled, they have momelotinib as the preferred option for a change, or have not been on momelotinib before. So this could include frontline. Then with other considerations, there's data for the use of pacritinib in this setting with anemia, ruxolitinib combination, luspatercept, ESAs if the EPO is less than 500, or danazol. This is a change in the NCCN guidelines. When we first did them, we had fewer options, and a mandatory EPO decision step was present. I think it's appropriate that this has really been kind of downgraded. You know, EPO can have activity. It's not overwhelming. I don't think that people have to have failed EPO to have more definitive therapy. Individuals that are controlled on a JAK inhibitor, again, clinical trials are always a strong consideration. Other considerations, Rux combinations, luspatercept, or change to momelotinib or pacritinib. So here, kind of digging in a little deeper with no symptomatic splenomegaly. This is an important distinguishing point. Then you can be thinking about luspatercept, ESAs, or danazol. And if they don't have splenomegaly, momelotinib or pacritinib still are considerations. They have them downgraded a bit as category 2B because they're more focused on the cytopenias. I'd say if they have symptoms, again, certainly that makes it more intriguing. They again here say anemia without symptomatic splenomegaly or symptoms. Again, they're likely to have symptoms, particularly if they're that cytopenic. I think the number of individuals that have really severe cytopenias and don't have symptoms or splenomegaly is a vanishingly small group of individuals. And I'm always doubly sure to be sure that there's not really a confounder, that they really have a hemolytic anemia or something else. So now the role of momelotinib in these patients, and now momelotinib, the most recently approved of the JAK inhibitors, was on a series of different phase 3 trials, but the most recent one was the Momentum study. And this was a second-line study. Patients had been previously treated with a JAK inhibitor. They were symptomatic, anemic, and they were randomized against momelotinib versus danazol, and then with an open-label crossover to momelotinib. It's bringing back memories because I think it was 2 years ago that presented here in an oral abstract at ASCO, the MOMENTUM study. In this study, it met all of its endpoints. The primary endpoint was superiority in terms of control of symptoms, and then secondary endpoints of non-inferiority in terms of, superiority in terms of control of splenomegaly and non-inferiority for anemia. And here is data showing the sustained responses through week 48, both in terms of symptom response, transfusion independence, spleen volume response. It's notable that danazol was active for cytopenias, just certainly at best non-inferior. It was very close that the momelotinib was almost statistically superior, but really did not have that much activity in the other arms. Still remains probably one of our most active other agents out there for solely cytopenias. We've had an update, and there'll be an updated poster on long-term survival on June 3rd, and I would just call everyone's attention to this for folks to be able to go and learn about this in greater detail, but you see the differences in terms of the open label period and differences there between the momelotinib and the danazol. Now, as one looks at the time and the impact, so some key takeaways of momelotinib impact on the quality of the survival that patients have. One, they have spent much less time relying on red cell transfusions. You see in the graph on the right, which tries to give a bit of a graphical feel to the time in each health state, transfusion dependent or kind of intermediate transfusion requiring, and you see the significant difference between ruxolitinib and momelotinib. Additionally, there's a variety of analysis that suggest the benefit with anemia also leads to an improvement in quality of life, as well as quality of their survival. And of course, that's logical: increased oxygen carrying capacity, better oxygen organ function, all that are augmented by improvements in anemia. Luspatercept is also active in this setting, now approved for both hemoglobinopathies as well as low-risk MDS, with data both in combination as well as single-arm or a monotherapy. The combination appears the most intriguing. There's currently an ongoing phase 3 independence study that is not reported out yet, but is of great interest in terms of potentially leading to an indication. Certainly, luspatercept is being used somewhat in the off-label setting, even at the current time, and is included in the NCCN guidelines. Pacritinib is also active for individuals for both spleen and symptoms, of course, but as well as cytopenias. Here showing pacritinib improving spleen and symptom responses with patients with low baseline platelets. This is the PERSIST-2 trial. These are individuals with a platelet count of less than 100,000, and again showing superiority as it related to spleen volume response, as well as improvement in symptoms, as well as those with the platelet count of under 50,000. So certainly a consideration for under 100,000. The FDA indication is for under 50, but certainly our guidelines would suggest consideration at higher levels as well. Adverse events can include GI-related side effects, as well as cytopenias. Always a little difficult to just sort out the cytopenias. Are these just non-responders that came in with baseline cytopenias? There is, you see there a bit of an increased risk of bleeding, and then compared to BAT, not a difference as it was related to cardiac events. Now, what about lower dose ruxolitinib in patients with lower platelet counts? Certainly, we now have more than 10 years of experience with this. There have been a lot of patients who have been treated at lower dose. Overall, the quality of the responses is less. Certainly, there are outliers that have had some benefit. I've often said that being on a low dose of a JAK inhibitor beats being on no JAK inhibitor at all. You know, we typically had built the NCCN guidelines to really avoid patients having to be forced off a JAK inhibitor, because I do think a JAK inhibitor can bring some value for patients. But overall, we found that the strongest responses, as well as the strongest suggestion of survival benefit, has been for those individuals that are on a solid dose, 10 twice a day, or usually even more than that. So some practical considerations of momelotinib: 200 milligrams once a day. Most common toxicities, again, low blood counts, hemorrhage, bacterial infection, GI. One needs to monitor for signs of infection, although it's usually not a major limiter. Cytopenias, again, sometimes are really just pre-existing and need to be managed accordingly, and need to follow for hepatotoxicity, but again, usually not overly limiting. For pacritinib, more perhaps GI side effects. I do tend to prophylax with those, but usually I'm able to stop that GI prophylaxis. Probably would hold prior to surgical procedures, so there's slight increased risk of bleeding. There are recommendations of not using in those with prolonged QT intervals, as well as those with significant QT interval elevation. So let's say this first case that we had discussed earlier had come in with a hemoglobin of 6.5. Naveen, how would that have changed your approach?
So in this patient, if you have that degree of anemia, 6.5, that gets our attention. So you have spleen, you have symptoms, you have anemia. I think this is a great one to consider, the newer agent, the momelotinib, on-label FDA-approved indication, and as you showed in the momentum data, you're hitting all three: spleen, symptoms, and the anemia. So I think that's a decent first choice in this situation.
And John, if the platelets were low, let's say they were 60, would that change your choice, momelotinib versus pacritinib, versus, let's say, a platelet count of like 25?
I think at 60, you could go either way, momelotinib or pacritinib. I think at 25, the data really is strongest for pacritinib. Sure. And I think to play devil's advocate to the response Naveen gave, I mean, one could give ruxolitinib and add on an ESA or luspatercept too to this patient if the platelet count's greater than 100,000.
Wonderful.
Nice.
So a couple take-home points. Patient with MF-induced anemia. One, this individual still was clearly not controlled. He had been JAK inhibitor naive with a hemoglobin of 6.5, clearly would meet the current indications for momelotinib, and I think would be an outstanding candidate for that. Be very consistent with the Simplify-1 data, and I think that'd be an outstanding way to go. I think you're right, John. The data in momelotinib includes 25 and above, but clearly the deeper one gets into severe thrombocytopenia, certainly data does tend to favor pacritinib, although there's no head-to-head data. The more anemia is the main driver, I think the more momelotinib has the stronger kind of evidence portfolio to share. If they had been stable for a long time, they'd been doing all okay on other parts, perhaps luspatercept, and then severe thrombocytopenia, of course, pacritinib. Wonderful. John, why don't you take us on to the third aspect of this?
All right, fantastic. Thanks for the lead up to this, to Naveen and to Ruben. I'm going to start with a case like my colleagues did. So this is Sarah. She's 71. She has high-risk myelofibrosis. She is not eligible for a transplant, so we're not going for a curative route with this patient. She has a calreticulin type 2 mutation, so this is a 5-base pair insertion, perhaps not as favorable as our calreticulin type 1 patients, but as Naveen pointed out, probably is not going to really influence our treatment decisions. It's just duly noted. So she starts treatment with ruxolitinib as a first-line agent, and then gets sequenced to an alternative JAK inhibitor after 2 years due to loss of response. And there's a lot of data, both from prospective data and retrospectively. The median time to discontinuation of ruxolitinib is somewhere between 2 to 3 years. So this is not too far from what we see in real life. In her case, she has increasing splenomegaly, and the spleen is now measured 11 centimeters below the left costal margin. So the question is, in this setting, where we have newer mechanisms of action, can we make a difference outside of the traditional JAK inhibitor space that we've become very accustomed to? And with that, I'll start with with navtemadlin. Navtemadlin is an oral MDM2 inhibitor, and this is inhibiting an interaction between MDM2 and wild-type P53, not mutant P53. And MDM2 is potently upregulated in patients with MPNs, PV and MF, due to JAK-STAT signaling. And it negatively regulates. It binds P53 and leads to degradation through proteasomal ubiquitination. So it's a way of controlling P53-mediated apoptosis and cell senescence, and this inhibitor turns on the P53 pathway selectively in MF cells, because this is only a window of opportunity in that patient, in that cell population. And what we've seen previously is that navtemadlin has significant activity as a single agent in the relapse refractory setting, and really, I think impressively, combination agent, synergistic agent that was shown preclinically and then confirmed clinically in patients who were receiving ruxolitinib with a suboptimal response in terms of improving upon both spleen and symptom response and hitting those endpoints in at least a third of the patients with the addition of navtemadlin. Navtemadlin is given intermittently, so 7 days on, 3 weeks off. And this is a drug that has both rationale and significant clinical correlative data supporting on-target activity and disease modulation. So the Boreas study was, and I'll say was because it was stopped for a newer study that's coming out, a definitive phase 3 study evaluating navtemadlin in patients who have failed ruxolitinib or first-line JAK inhibitor therapy, and they were randomized to navtemadlin versus best available therapy, excluding a JAK inhibitor, with the premise that these patients were really not JAK inhibitor responsive. So giving them a totally different mechanism of action that's dependent on P53-mediated killing. And this is a study that has yet to be read out, but I think is an important study adding to the literature and validating this target, MDM2, P53, as a viable, important target and therapeutic in this field. But the study I think that's more interesting, that you should pay more attention to and worth discussing, is the POESIS study, which is the newest study by Kartos, which is an add-on strategy to ruxolitinib for patients who are suboptimal. And this is a very innovative study design. I would say iconoclastic in its design. It's not the usual, you take the patients, you put them on the study drug up front, and or you take a bunch of patients who have been historically treated with ruxolitinib and have inadequate responses. But this is really the cleanest study design you're going to see. 600 patients enrolled up front, assessed up front for spleen, symptom burden, and then followed, and at some interval, close interval, after 16, 18 weeks of therapy, reassessed for response. If they are responders by symptom or spleen, they're off. They're doing well. They received their single-agent ruxolitinib. That's a positive response. If they do not respond at all, then those are refractory patients. They can come off and go to the appropriate trials. But if they're in the middle, the suboptimal responders, they haven't hit 35% SVR, they haven't hit TSS 50%, to then get them over that finish line, patients are randomized in a 2-to-1 fashion to navtemadlin at 240, 7 days on, 21 days off, versus best available therapy, or placebo in this study. So this is a study that will, and in this study, you simply have to improve the response rate to get it over the regulatory endpoint of SVR 35% and TSS 50. So this is an important study to demonstrate that navtemadlin as a combination can salvage these suboptimal responders and provide them with much deeper responses. So very innovative study design, the POESIS randomized phase 3 study. What about hitting pro-survival molecules? So this is a story that Naveen is very intimately involved in, which is the combination BCL-XL inhibitor. BCL-XL is very upregulated through JAK-STAT signaling. It's a target in myelofibrosis, and this has been shown over a decade. Even Ron Hoffman and others have shown this in beautiful preclinical data in primary MF cells. Ruxolitinib, to some extent, does downregulate these pro-survival molecules, but the combination of navitoclax, which is basically a cousin, an older cousin, of venetoclax, which is a BCL-2 selective agent that we use in AML. It inhibits both BCL-XL and BCL-2. So this is a very nice way of combining to synergize on changing the imbalance between pro-survival and pro-death signaling from the mitochondria in favor of inducing apoptosis in MF cells. And the preclinical data, again, and all of these studies, the preclinical data supports the clinical investigation of these agents, and that's what really makes this important. These are really not guesses to see if things are going to work. This is really driven by science. So the refined study, the phase 2 study that Claire Harrison published last year, and many investigators were involved with, including Naveen, took the concept from the lab and said, okay, we're going to treat patients with ruxolitinib. If they have a suboptimal response, spleen and symptom burden that's unmet, we're going to add navitoclax at 50 milligrams and dose titrate up to a max of 300 with attention to platelets. When you inhibit BCL-XL, you are going to get on-target treatment-emergent thrombocytopenia. That was always known, always recognized, and the team did as best they can to mitigate that risk while maximizing the benefit of inducing apoptosis in these cells. And you can see from the waterfall plot, this was quite successful in attaining spleen responses, symptom responses, and even bone marrow fibrosis reduction of 30%. Now, I will take a side and say, if you look at any of the studies that I present, Naveen presents, Ruben presents, or anyone presents, it's almost a third bone marrow fibrosis reduction in all of the studies. Now, whether that's clinically meaningful, the onus is on us as investigators to prove that when you reduce fibrosis in someone with a novel agent, that actually correlates with outcome measures that actually matter to patients, because patients don't know when their fibrosis is less, but they do know when they feel better and live longer. So we have to do that correlation. That's really key. What about telomerase? So telomerase is a really interesting enzyme. It's a complex, actually, ribonucleotide protein complex that is important for elongation of chromosomes, and it is only transiently expressed in malignant stem cells and progenitor cells. Only transiently expressed in normal stem and progenitor cells, but constitutively expressed in malignant cells, which gives us a window of therapeutic opportunity to poison this enzyme, to disallow it for adding with each cell division DNA caps to the chromosomes. What happens is eventually, if you have enough cell division, your chromosomes are too small, and then the cell is induced to undergo apoptosis. So this is a way of eliminating the fountain of youth through this mechanism in malignant cells. And this is not even particular to MF. In many malignancies, this drug has been evaluated across solid malignancies, malignant malignancies for over a decade, well over a decade, but actually has some of the most interesting data here in myelofibrosis. And for those of you that are interested in MDS, you probably are aware that the phase 3 data in transfusion-dependent lower-risk MDS, irrespective of SF3B1 mutation, was a positive study with durable responses in transfusion independence. So what is interesting here is in MDS, a related disease, bone marrow failure, using it in lower-risk patients for an anemia benefit. But here, we took the drug in higher-risk patients who had failed ruxolitinib with a median survival predictive about a year and a half, and treated them with imetelstat at 2 different doses, 9.4 milligrams per kilogram. That's the dose that Ayala Teferi used in the phase 1 study that showed us the initial response with this drug, versus a lower dose, 4.7 milligrams per kilogram. And what you can see by those survival curves is that there was a difference in survival in patients who had the higher dose. So multiple studies, including a propensity score match we did with Andrew Kuykendall at Moffitt, would suggest 12 to 14 months. At the low dose, maybe about 20 months. At the high dose, 30 months, suggesting that there is a dose-dependent improvement in survival with imetelstat in this very advanced patient population who's failed JAK inhibitor. There was spleen response. It was modest, 10%. There was symptom response, 30%. So these patients do feel better, so that's important. And there was significant reduction in fibrosis, 40%. And if I go back to my original statement, here's a slide showing an attempt to show a correlation between reduction in bone marrow fibrosis with survival. Correlating biomarkers, which we lack in MF, with clinical outcome measures that matter to the FDA and matter to the patients and matter to us as physicians treating the patients. So the IMPACT MF is the ongoing randomized phase 3 study of patients with myelofibrosis who failed ruxolitinib. They're randomized in a 2-to-1 fashion to imetelstat. This is an infusional agent Given every 3 weeks over a 2-hour infusion, it is associated with cytopenias that are reversible and mild GI toxicity versus BAT, no JAK inhibitor in this study. So BAT without a JAK inhibitor. The primary endpoint of this study is survival. It's the only study I'm aware of in MF where an ambitious survival endpoint is looked at. So I'm still very excited to see how that study pans out. I will point out that it doesn't stop there. There's really great clinical data to suggest from Ron Hoffman and colleagues at my institution that the combination of imetelstat plus Rux is very synergistic, not wait for patients to fail ruxolitinib. So here's a study where we take patients who have been on ruxolitinib, who still have unmet spleen and symptom burden, and add imetelstat in a phase 1b dose escalation format with an expansion at a recommended phase 2 dose. This is an ongoing study in which maybe at ASH we'll have some preliminary data, if not ASCO next year. So stay tuned to that. So single agent in relapse refractory setting, survival is an endpoint. Here we're trying to salvage responses in suboptimal responders as an add-on strategy. So can newer mechanisms make a difference in the first-line settings? So for those of you who've really been paying attention, probably the biggest movement in this field from a clinical development standpoint is add-on or combination strategies up front in JAK inhibitor-naive patients. This is data from the MANIFEST-2 study. The MANIFEST phase 2 study gave us the data, showed us that pelabresib, the pan-BET inhibitor, this is an epigenetic modifier that really works on NF-kappa B and NF-kappa B-related gene expression, was active as a single agent, was active as a combination in the suboptimal responders, but looked best in combination up front. And this is what the data shows in the phase 3 study, that you had doubling of spleen volume response when pelabresib was added to ruxolitinib compared to ruxolitinib alone at 24 weeks. So here's some of the first data out there from a large phase 3 study, over 300 patients, demonstrating doubling of spleen volume response compared to single-agent ruxolitinib. You also saw improvements in bone marrow fibrosis and less worsening of bone marrow fibrosis in the combination than you did with single-agent ruxolitinib. And of course, what's nice about this is parallel patients over multiple centers. Transform-1 is important to look at because this is a similar approach, navitoclax, as I showed you before, up front with ruxolitinib. Again, very similar, doubling of spleen volume response compared to single-agent ruxolitinib with this agent. I think the differences between the two drugs is pelabresib was a little bit better tolerated from a hematologic and non-hematologic toxicity profile. Here you had on-target BCL-XL mediated thrombocytopenia, even neutropenia, which complicated the story. Both studies, unfortunately, failed to beat single-agent ruxolitinib for symptom response. I would argue because it's very difficult, perhaps impossible, to do better than ruxolitinib in a symptom response. So we need to be more creative. We've spent at least 85% of today just speaking about how to do that, and that's the topic of drug development and clinical investigation. How do we really develop trials that really display the full benefits of novel agents, either in combination or as single agents, when we have an excellent drug, ruxolitinib, that already helps many of our patients but is inadequate over the long run. So to go back to our case of our lady Sarah, who's not a transplant candidate, who had treatment with first-line Rux, then goes on to second-line Rux, but really doesn't have the response, and the spleen is increasing. What do you do? And since I've got the podium, I'm going to send this over to Ruben for the discussion question. So what would you do here? Would you consider another JAK inhibitor, or would you say this patient is JAK inhibitor refractory?
Great.
Well, so this one, so frontline ruxolitinib, CALR type 2, so higher risk. One, without question, this individual would still technically qualify for pacritinib. Certainly fits with the JAKarta 2 study that we did, and if you did not have access to a clinical trial, then I think that clearly would be a consideration. We don't know too much about the cytopenias, about the other two. You certainly have discussed kind of a range of additional data. None of those other options, of course, are approved. Right. So outside of the setting of a clinical trial would not necessarily have them available to us. But let me punt it then to Naveen. So again, let's say you could use one of those other options. Where might you use? Would you consider a middle stat? Would you add on pelabresib or navitoclax? Navtemadlin's data is interesting. What do you think?
Yeah, absolutely. I think the key is, as we said in the beginning, this real-world patient we're saying is not eligible for transplant for whatever reason, comorbidities, et cetera. And so I think we have to start thinking about our paradigm as turning this into a chronic sequential disease therapy. My preference here would be a clinical trial. We mentioned several. John, that was a great overview of really the strategies of add-on. And then even in the case of the imetelstat, you showed overall survival as a goal in the second-line setting. It's a good chance to remind folks that we have mutant-specific therapies now, so the era of CALR-specific mutation is starting. So there are active CALR-directed therapies, monoclonal antibodies, bispecifics, and vaccines. So put me down for my preference would be to potentially go for clinical trial here, gentlemen, in the second-line setting, and then go back to the JAK inhibitors as standard of care. And I just want to put out there, again, even if you're stem cell transplant ineligible, let's make it a dynamic process. You may become eligible later on. Something could change.
Wonderful. So we're almost at time, and we've got a couple questions. But John, why don't you give us our take-home points?
Yeah, so I think the take-home here is that using another JAK inhibitor in someone who's failed 2 JAK inhibitors with progressive splenomegaly is probably unlikely to benefit from the next JAK inhibitor. And that might be the only option for someone who lives perhaps outside of Boise, Idaho, or somewhere where maybe there's not a lot of options. So, I think clinical trials is always, in a multiple choice question, particularly for fellows, it's always the right answer. Is you really got to look at clinical trials in this space where there's unmet need, particularly with different mechanisms of action. I think a conversation with the patient about what her goals are, if her goals are survival, then imetelstat, I think, is a really good, If her goals are, palliation, quality of care, quality over everything, then maybe another drug, maybe the TP3654 Sumitomo drug would be an interesting option. I think there's a lot of things out there. I would definitely consider navtemadlin or other drugs that have efficacy in this relapse refractory setting, particularly for spleen.
Yep.
And I think I'll stop and hand it over so we can get to the questions.
Don, let me just throw each of you just a couple questions that kind of synthesize the actions out there. So first, Naveen, PAC versus modified Rux versus momelotinib, individuals with the low platelets. How do you select between there?
Yeah, I think this is a great question. I think it reflects a couple of different practice points. One is we don't have a biomarker yet, so we are basing it on the clinical factors we showed here from our own trials that we've led, NCCN guidelines and practice points. But I would actually say I'm taking into account patient comorbidities. That was one of the top choices there. So John had mentioned, I am now in the new era of JAK inhibitors beyond Rux, looking at GI and GI diseases. So if a patient has Crohn's disease, bowel disease, et cetera, maybe trying to do a little bit more education and thinking before I go for pacritinib, momelotinib, fedratinib. 2 also is I'm looking at their infection profile, and other comorbidities that they've had in the past, so immunosuppression. Then 3, also, sometimes the platelet count is not a static thing. It can actually change over time, so I think that's something that can be reevaluated. But I want to emphasize that we have no biomarker, and overall, I'm still looking at platelet as the number 1 deciding factor, and then comorbidities as 1B.
Wonderful. And John, maybe I'll throw you the final question. What is the most realistic potential for addressing bone marrow fibrosis in the front line, given JAK inhibitors are likely insufficient? Are we thinking about a multi-drug approach? And if so, which combinations would make the most rational sense? And throw in there, just from the questions, interferon in a JAK inhibitor or some of the other combinations that you covered.
So, I think we've learned a couple of things. One is that the JAK inhibitors themselves, and perhaps momelotinib versus ruxolitinib from Steve O's data, would suggest that reduction in fibrosis that we see with those drugs don't seem to actually correlate with any of the clinical outcome measures. So that's, I think, an important observation. But I would suggest that doesn't necessarily mean that in every setting with different mechanisms of action, that reduction in fibrosis doesn't have some correlate. So I think in the absence of anemia responses or survival benefit or something else that's tangible, probably reduction in fibrosis is an epiphenomenon of just reducing the inflammatory cues in the bone marrow. I think we're probably most likely going to see deeper responses. I think we're seeing them, actually. It's just we have to prove it in prospective studies, but deeper responses with combination therapies. So we're talking about pelabresib, navitoclax, navtemadlin, perhaps selinexor. I mean, these drugs are all active. They all have rationale. They're all mechanistically rational. I think what we don't know yet is if we get this more significant reduction in fibrosis, reduction in cytokine signaling, reduction in JAK2 V617F allele burden, is that actually meaningful to the patient? And that, I know, is what the FDA is also looking for. So that's something that we need to prove. Which one is better than the other? I don't think we know. We don't have any head-to-head. I think they all have that potential, and probably a world will exist where we will tailor those combinations based on profiles, perhaps molecular profiles, but we're not there yet.
Wonderful. And maybe I'll answer the final one. Is there potential for ropegol interferon plus a JAK inhibitor or BET inhibitor as bridging therapy to lead to transplantation with an RIC? Well, certainly, interferon and a JAK inhibitor, I think prior to transplant certainly could be considered. Certainly there is intriguing data that's shown by Jean-Jacques Kilojan about the benefit of that combination. I think we need more data. I think we know interferon well enough that there's probably not a lot of pre-transplant concern. The BET inhibition is an intriguing question, although my only concern is, we don't really have data as it relates to safety of a BET inhibitor immediately before transplant. So, in theory, I don't think that there is a concern, but I think we would need to be cautious. I think we've learned over time that, a JAK inhibitor before transplant is safe. I think we've learned more about, trying to, stop that on day 0, or if people are on a very high dose of ruxolitinib to kind of taper them down. John, Naveen, thoughts in terms of kind of doubling down on therapy, kind of pre-transplant? They think we need a bit more safety signal, but what do you guys think?
I think I like the fact that you brought up this Ruxo-Peg study of Jean-Jacques. You and I were discussing a case of a young patient with a TP53 mutation that I had. So someone with high-risk features, someone that you really, time matters, you're trying to decrease the disease burden, have disease modification, pre-transplant. So a young, fit patient, someone who's transplant eligible, and then you saw the data with some of the newer drugs, navitoclax, pelabresib. We didn't show the data here, but several of those patients were able to be bridged to successful transplants. John?
Yeah, I don't think we know how deep of a response do you need to enjoy the optimal benefit from transplant. Even there was a question here about how small should the spleen be before you go to transplant. Different centers have different requirements. I think the era of splenectomies is out. But if you use spleen as a surrogate, I don't know how much disease reduction do we need to optimize. I think in other diseases, there is some data that would suggest that the less disease you have, the better the outcome with transplant is going to be in terms of a GVL effect. I would argue here it's not too clear.
And Ruben, if I can add just to that great point, that's where I think the disease modification story matters, to correlate what John said, transplant, bridging to transplant, OS, PFS. This may be a new era of disease modification for some of these drug combinations to reflect, in addition to spleen and symptoms.
Wonderful. Well, it's been a wonderful discussion. Thank you, Naveen and John, and all of you for attending here and attending online.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This educational activity is supported by independent medical education grants from Bristol Myers Squibb, Geron, GSK, and Incyte Corporation. This activity is certified by PVI, PeerView Institute for Medical Education. To access all materials for this activity, visit peerview.com/AQJ860.